Okay, so big culprit, side sleeping. How many people in here call yourself a side sleeper? Okay, so we call ourselves side sleepers, and I hope that slide is next. We're actually left anterior and right anterior oblique sleepers. Okay, if we were truly stacked on our side sleepers, we wouldn't be having this problem. Okay, but that's kind of one of the things you're looking for in the patient's history. You know, asking if they're side sleepers. And then another big hint for your suspicion that this is proximal, and in this case, you know, our postural positional thoracic outlet syndrome, or our, you know, compression of the neurovascular bundle in the upper chest, is that they have multiple positives on palpation or on Tinel's. So as I'm learning to do this, you know, I do your left arm, I do your right arm, and it's like you're positive for everything. And I know that it's not that I'm doing it wrong, because I have other people who aren't positive for everything, but you are positive for everything. And I'm thinking, well, now, you know, really, what would be the odds that they would have bilateral carpal tunnel syndrome and entrapment of the ulnar nerve at Guyon's canal at the wrist, and compression somehow of the dorsal branch, you know, radiosensory branch of the radial nerve at the wrist, and pronator syndrome for median nerve in the forearm, and, you know, really, seriously, what would be the odds? I mean, the orthopedic surgeon would be like, you know, they died and gone to heaven. Yeah. So, you know, I'm thinking, it makes a whole lot more sense that whatever's happening is happening higher up, you know, where things are common. It has to be happening before that brachial plexus divides off into those individual nerve distributions, right? I mean, really easy after you struggle with it a while, right? So, and then finally, a positive ruse. Has anybody ever heard the ruse besides me? Okay, I got a slide in here. We don't have a YouTube clip, but if you really want one, we probably jazz one up for you when I'm talking again. So here's a pearl. How many people have heard of double crush or multiple crush? Now, your surgeons like to talk about double crush, which is like way too simplified. I mean, here's another big, you know, no-brainer. How easy is this? Proximal compression of a nerve lessens its ability to withstand more distal compression. So that means wherever that first insult is, even if it's just temporary, even if it's just posture and position, that nerve is going to be hyper-irritable for the rest of its distribution. So to me, you know, it's certainly not a double crush. I mean, that infers, okay, you got a crush here and here. You got a crush here. Say again?
Like waking up on the wrong side of the bed.
Yeah. It's all the way down, right? So wherever that first insult is, that nerve or those nerve distributions are totally insulted the rest of the way down. Okay, and then I think this is also from the Kasdan book, but any of these things you see are definitely, most of them came from different chapters of the Kasdan book, and then one from the Saunders. Okay, so postural, positional, occupational compression of the neurovascular bundle in the upper chest, particularly from sleeping, particularly from driving, particularly from working at a desk. Okay, the finding of a cervical rib is usually incidental. I mean, I've seen a fair handful of cervical ribs in my career, but they didn't have any symptoms, you know. I mean, it's just that whatever reason they've had maybe more muscular symptoms than we do the films, and lo and behold, I think I have one cervical rib film in here for you. And then the vascular anomalies are even more rare. So, okay, here's like my most favorite slide ever. Yes. Okay, so this is from Netter's, and my brother took out about 2/3 of the identifications on this slide, believe it or not. When you pull it up in the book, it is like the busiest thing ever. But when you have the Netter's presenter, you know, to be able to import the slides into PowerPoints, you go in and you click on what you want. So, of course, you know, everybody knows the yellow part is brachial plexus, and the red and blue, what are those? Subclavian vein and artery. Okay, and then this muscle here, this one, pectoralis major, and here's pectoralis minor, and then what do we have split right here, cut away to see? The clavicle. So you kind of put all this stuff back together, and you can see there's lots of opportunity for, muscle tightness. And if you put your muscles in a shortened position for most of your waking hours, what happens to muscles when you put them in shortened positions? They don't get longer, right? They shorten. So now when you come back in good posture, now you got really tight muscles pressing against. So when you're talking to patients, and I pull this out, I have like a flip book, page protectors and stuff, and they're called Crane's favorite things, and so I bring that out with my patients, and so this picture we bring out all the time. And you can tell your patients, this is like your chicken breast and your chicken breast tenderloin. And this is like the water, sewer, and electric to your entire house, or in this case, your entire arm. So do you really want to, sleep like this? And when you sleep like this, you're really compressing both sides, right? I mean, do you really want to compromise the flow of electricity, water, and sewer to and from your house on purpose? Okay, this is hard to see. So, can you see? Okay, so everybody see this faint shadow here? This is the first rib. Okay, so then this must be T1, yes. And then here is the first rib on this side. Everybody see that? Okay. And then this one's a little nubbin, but over here, you got like this segmented thing. See this? And then there's like a joint, and then here's a segment. So this is actually a huge cervical rib that's actually fused to her first true rib. Trauma, huh? She probably had surgery. I've only had a few clients after the cervical rib, which, knock, who's there? Obviously, it didn't take care of the problem. They're coming to see me a year and a half later after this surgical procedure that was, how many patients have you seen that have bilateral carpal tunnel release scars? Okay. And so, having been around the block a year or two, I think they go in and they hack these things out with no regard of what ligaments or what muscles are attached, and they just hack them out and, leave stuff hanging. That has to have some implications, right? If you've got anomalous bony anatomy, there has to be some more anomalous stuff to go with it. And you think, well, it's causing problems, you need to do something about it. But if they're back in your chair a year later, we didn't exactly pick the right thing to do about it, I'm guessing. Okay, so provocative tests for ruse. Your starting position is like this. Okay, so you want your almost like, I just tell patients, almost like you got your back and your arms against the wall. And so your upper arm should be roughly parallel to the floor, and your elbows about 90. And you're going to, and look straight ahead. Because if the patient's having unilateral symptoms, they will look at that arm, like it's going to, I don't know, turn into a pumpkin or something. But they just, so if I'm looking, this is the arm that I'm having symptoms, and I'm looking at this arm, what does this do to my test? It actually potentially would give you a false positive if you're looking to the same side as your affected side. So tell them, look straight ahead, head level, and you open and close slowly. This is almost like an ADD test. You have to tell them slowly 3 times. Perhaps you might want to consider, checking yourself out for ADD. Slowly, and you don't have to make a big tight fist. It's just easy and slowly. Okay. And you do this upwards of 3 minutes. Okay? Now, everybody's arm's going to feel tired and heavy after 3 minutes. But you'd be surprised. And like when you're testing, you're not supposed to tell the patient what you're looking for, blah, 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 blah. I tell the patient what I'm looking for. Because no one wants to tell you that their arms feel tired and heavy. They'll say, well, are your arms heavy yet? Well, yeah, but, I'm really out of shape. You may or may not be out of shape. That's beside the point. This is a vascular symptom. This is what I'm looking for. And then I'll say, does one arm feel heavier than the other? Yeah, actually my right arm feels heavier than the left. Your right arm is more out of shape than your left. So I tell people, I might not say it right away, but I'll ask them, a few seconds in, 20, 30 seconds in, do your arms feel heavy or tired? And, and explain to them, this has nothing to do with you being out of shape. You may or may not be out of shape, but, this is a vascular symptom, this is one of the things I'm looking for. Sometimes patients will report the exact same symptoms that they came in with, and sometimes not, but I just like to record everything. doctor told me one time, there's sorters and groupers, and you are definitely a grouper. But I think it's like sort and group, wash, rinse, and repeat, right? So you start looking for trends, you know, and so where doctors say, you know, don't tell them what you're looking for, or they'll say these things like, you know, they'll roll their eyes at you and they'll say, the exam didn't correlate with the history, meaning the patient's, you know, making it up, or the patient's, you know, looking for attention. Do you find that with your patients? I don't. If anything, I find that patients tend to under-report pain and symptoms, you know. So I trust my patients. I do kind of give them a clue about what I'm looking for, and I say, you know, tell me everything. You know, like with this exam too. It's like, because sometimes, you know, I say nothing, and they'll say, no. I say, well, why did your eyebrow do that thing? And they'll say, well, it wasn't most, you know, I could stand it. Oh, excuse me. Okay, so maybe I should start every exam by saying, I'm not looking for the worst pain you ever had. You know, so I tell them, this is like a scavenger hunt, you know. This is a fact-finding mission. You know, this is like a mystery. I'm looking for clues, and sometimes the clues are very subtle, so tell me everything. You know, because if you don't, I'm going to see your face do the funny thing, and I'm just going to have to ask you anyway. You know, and so just tell me. If you don't know, I'd rather you say, I'm not really sure about that one. And we can either do it again, or, you know, compare it to the other side, or just write down a question mark. But, you know, tell me everything. I'm not the person to hold out on. That's what I tell them. So, any questions about the ruse? Okay. So, okay. Really? Okay. What side am I looking at? It must have auto-corrected. This was supposed to be capital E, upper extremities. Oh yeah, show and tell. So they're doing this thing, and I tell them, if you do feel something, it's easiest to just drop out of it for just a second and show me, and then come with your head right back around in your arm and just go right back into it. Okay? Okay, I'm not going to go through these. This is in your PowerPoint, and it's also in your the handout from my evaluation template. These are just some blurbs that I frequently use in my assessment section when this is where I'm going with the patient. And I can tell you that this is where I'm going more than anything else. I'm going here more frequently than the other upper or proximal, provisional, or differentials. I'm going here far and away more than carpal tunnel or cubital tunnel or any of the tunnels or any of the elbows or any of that stuff. Huh? I'm about halfway. We're halfway. We're doing good. Okay. Everybody feel like we're doing good? Okay. If you need to stand up or stand against the wall or, you know, move around. Okay. So the treatment plan. Well, even though I'm convinced, and, you know, I'm usually arrogantly convinced because I'm just that way, that it's, you know, compression of your